Picture this. You're right there at the bedside. The patient sitting in front of you is pale, they're clearly fatigued, and you just know it's anemia. But almost instantly, your mind starts racing, right? You're flipping through mental textbook pages of complex lab panels, endless diagnostic criteria, and all those dizzying cellular descriptions. Honestly, it can feel completely paralyzing. Well, welcome to The Explainer. Today we are going to break down a beautifully structured, absolute game changer of a shortcut for diagnosing anemia types. And the best part, we're doing it without relying on those complex, time-consuming lab results. We're going to take the historically overwhelming world of hematology and distill it down into a logical, purely clinical flow that you can literally use today. Let's just start by validating a very real frustration that pretty much all medical students and practitioners feel when they're trying to master hematology. There's this quote from a medical student that just hits the nail on the head, capturing this collective grievance perfectly. "I really get upset from all this kinds of anemia. I really confuse it." And seriously, who could blame them? You open any textbook and you're immediately hit with a giant wall of acronyms. I'm talking MCV, MCH, TIBC, reticulocyte counts, and this is all before you even lay eyes on the actual patient. It is so incredibly easy to get your wires crossed, and the cognitive load is just massive. So how on earth do we cut through all that noise? And that leads us to our core question for today. How do we get a solid general diagnosis without waiting around for investigations? Like, instead of waiting hours for a printed piece of paper from the lab to tell you what to do, what if you could form a highly educated hypothesis purely based on the living, breathing person sitting in front of you? We're going to build a clear, step-by-step clinical decision tree based entirely on physical observations. We are talking about fundamentally shifting your mindset from being lab-reliant to observation-reliant. It's about establishing a mental map that guides you straight to a general diagnosis using just a few extremely key physical clues. To really appreciate this paradigm shift, we need to completely bypass that overwhelming mountain of investigation-based diagnoses. You know the exact approach I mean, the one that requires you to memorize dozens of lab values, complex blood panels, and microscopic morphologies. We are throwing that out the window for a minute. Instead, we're focusing entirely on a streamlined, incredibly practical approach, the general physical diagnosis. Because let's be real, in a busy hospital ward, time is absolutely your most valuable resource. This physical approach is faster, it is highly logical, and it saves you from that paralyzing textbook headache, letting you connect directly with the clinical reality of your patient. Okay, so here is where it gets fun. Our general diagnostic framework operates on a beautifully simple principle. It sorts the patient into one of exactly three main categories of anemia. Just three. There's a profound psychological benefit to limiting your initial possibilities to a hard, small number like this. When you aren't trying to choose from 50 different highly specific options, your brain can categorize information so much more efficiently. You drastically reduce decision fatigue. You're no longer staring at this massive, tangled web of possibilities. You're simply narrowing the field down to three really clear destinations. So what are those three clinical destinations? We've got iron deficiency anemia, hemolytic anemia, and megaloblastic or pernicious anemia. That's the whole shebang. Every single physical clue we look for from here on out acts as a filter, directing us smoothly into one of these three specific buckets. I want you to think of this process kind of like a giant funnel. You start super broad with the patient in front of you, and with each targeted physical observation, you are systematically filtering out the noise until, boom, you drop right into the correct diagnostic category. So how exactly do we navigate this clinical funnel? Well, here is your sequential roadmap for the bedside. It's a rapid, three-step physical check. Step 1, check for splenomegaly. Step 2, check for chylonychia. Step 3, check for neurological manifestations. In real life, performing these three clinical checks takes mere moments. By simply running through this quick 1, 2, 3 mental checklist while you're examining your patient, you are actively driving the entire diagnostic process forward, and you haven't even waited on a single blood draw yet. Let's break down exactly how this first step sets the whole algorithm into motion.
Our very first fork in the road starts right at the abdomen. We are checking the patient for splenomegaly, which of course is simply the presence of an enlarged spleen. When you first walk up to your patient, before looking at their extremities or taking a really detailed sensory history, this abdominal palpation is your primary clinical checkpoint. It is the crucial physical act that kicks off our entire diagnostic tree. It takes all that abstract theoretical knowledge and immediately grounds it into a highly tangible physical finding. Now, the real power of this specific step is its clean, strictly binary logic. When you palpate that abdomen, you either feel an enlarged spleen or you don't. It is a straightforward physical reality. There's no murky gray area to overthink here, no complex reference ranges to try and calculate in your head. It is a simple yes or no. This is exactly why clinical algorithms like this are so incredibly powerful for your learning and retention. Each path gives us an immediate, massive clue and drastically narrows down our 3 initial categories. Let's trace that yes path first, shall we? If splenomegaly is present, the clinical fog just clears instantly. You are looking at hemolytic anemia. It is a highly satisfying clinical revelation. Just that single, distinct physical finding filters out the other 2 main categories right off the bat, saving you immense cognitive effort. You don't even need to wonder if it's an iron issue or a B12 issue right now. That enlarged spleen has confidently placed you straight into the hemolytic category. But actually, the true beauty of this shortcut goes even deeper when we look at how the subclassifications are organized.
Just think about the sheer relief this brings to anyone trying to organize their medical knowledge base. Instead of trying to memorize a chaotic web of separate, complex-sounding diseases and all their individual presentations, you now know that if you see splenomegaly, you are safely standing under the hemolytic umbrella. Conditions like thalassemia, neurohemoglobinopathies, the presence of spherocytes, they all live inside this one house. By linking all these specific anomalies to that one primary physical finding of an enlarged spleen, you vastly simplify your mental load.
Okay, but what happens if the abdomen is totally soft? What if the spleen is perfectly normal on palpation? Well, by establishing that negative finding, we have successfully ruled out the entire hemolytic family. And just like that, it leaves us with our 2 remaining buckets, iron deficiency anemia and megaloblastic anemia. The algorithm is working perfectly. To figure out which of these 2 remaining conditions is actually affecting our patient, we just need to advance to the next steps in our physical checklist.
To differentiate these final 2 options, we move our clinical focus away from the abdomen and out to the extremities. We are essentially checking the nails versus checking the nerves. It is a beautifully distinct physical divergence. On one side of the diagnostic fork, we're looking for koilonychia, and on the other side, we are assessing for neurological manifestations. By testing these completely separate body systems, we create a clear diagnostic split that leaves absolutely no room for confusion when you're standing right there at the bedside. So if you go down the first path and examine the patient's hands, you're looking for koilonychia. Spotting this distinct concavity, that classic spoon shape of the nails where they curve inward, means your algorithm stops right there. You are looking at iron deficiency anemia. I mean, think about how powerful that is. Once again, absolutely no complex lab panels were needed to achieve this general classification. Just a clear, specific physical observation on the patient's hands, leading directly to the correct bucket from our original list of 3. Conversely, if their nails are completely normal, you shift your focus and simply ask the patient about their sensory experience. If they describe neurological manifestations, like paresthesia, that classic tingling or pins and needle sensation in their hands and feet, while that physical clue maps perfectly to our final category, you are confidently looking at megaloblastic or pernicious anemia. That sensory response has beautifully completed our decision tree, providing a totally reliable clinical compass when the other physical signs just aren't there. So, look at what we've done here. You've just taken a massive, historically confusing textbook subject and completely turned it into a sleek, 3-step bedside algorithm. Check the spleen, check the nails, check the nerves. That's it. By internalizing this highly visual, logical map, you can approach your hematology exams and clinical observations with a profound sense of clarity. So, I'll leave you with this final thought. The next time you step onto the ward to evaluate a patient with anemia, are you going to allow yourself to get paralyzed by pending lab investigations?